So in California, we're really fortunate to have the regional center system that serves individuals and their families with developmental disabilities. There are 21 regional centers in California, and the regional centers are designed through the Land Turbine Act to be the single point of entry into the system and to be responsive to the local community around the regional center. In California, we have, as you know, a very diverse population, and so therefore each regional center needs to be responsive to the diverse population that they serve. However, despite some of our best efforts to be very open and collaborative and responsive, we have noted in the data that we have available to us that there still exist disparities of the services that are purchased in the system. And this, over the past several years, has become a real area of focus and concern for the Department of Developmental Services. Individuals who are served by regional centers there's an individual program plan that outlines the services and supports that they receive, and so this is one more way that the system is responsive to the individual unique needs of each person. The regional centers are, however, required to ensure that consumers and families access generic resources or natural supports that exist for the person. And then once those other resources have been looked into, the regional center uses their own funding, or what we call purchase of service, to fund services. Although we do have quite a lot of data that is available to us, we have both authorization data, and that means through the individual program plan process, the regional center authorizes services and amounts of services. And then we also have data that shows the amount of services that were purchased as a result of those authorizations. So as I was saying, we do have a lot of data available to us, but that data goes into a lot of consumer characteristics, as well as the authorizations and the purchase of service that regional centers use. As I mentioned earlier, there are generic services that are accessed by consumers and families, and so our data is imperfect in the sense that we don't know what services were purchased or were received from a generic resource, such as the school system, Medi-Cal, in-home supportive services, and the like. We also don't know about the family's level of income or education. So there's things that we don't really know in the data that we currently have available to us. We also we have a limited number of ethnicities that can be coded for consumers and families, and we have a category that's called other, and there's actually 4 different reasons why a person could be coded as other, and so we don't necessarily know who is in that category. So the second part of the presentation kind of walks you through some of the data that we do have available to us. We do know that older consumers receive more services than younger consumers. And this is obviously, as children are in the school system, the schools are providing most of the services for them. And you can see the large increase from 18 to 21, then up to 22 to 26. And this is significant because as the population in California has shifted to become more Latino, we also have the Latino population that regional centers serve tend to be younger. And since regional centers spend less money on individuals who are younger, this is an important factor to take into consideration. I also want to point out that the data that I'm presenting is from fiscal year 15-16. Regional center purchase of service data, there's a couple of month lag time, so we don't have the 16-17 data available to us yet. The biggest gap that we see in purchase of service is consumers who are Hispanic or Latino. You can see this is of each ethnicity, and you can see the large difference between what is authorized and what is purchased for individuals who are white versus those who are Hispanic. And again, this is just showing the gap between white and Latino consumers. The diagnosis of an individual doesn't have much of an impact on the data because we still see, regardless of the diagnosis, we still see a large disparity mostly attributed to the ethnicity of the individual. We track 45 different languages, but the vast majority of individuals in California speak either Spanish or English. But the fact that we do have so many other languages that are spoken in California, it does present a challenge for both regional centers and for service providers to be responsive to individuals who speak different languages, especially when those populations are smaller. So beyond ethnicity, we consider how language impacts access and utilization of services. Consumers and families who are not proficient in English face additional challenges in accessing services through the regional center system. It's no surprise that language barriers increase disparities within the Latino community. We also know that purchase of service also varies greatly based on the residence type of the individual. And so if a person is in residential care, the cost is much greater than if an individual remains in the family home and receives supportive services there. So this is also, we look at this because of the cultural preference to maintain families and the consumers in the family home for some cultures. And so if that's the case, then obviously less money will be spent. Whereas for the white community, we tend to have more of a value on independence and individuals residing in independent or supported living. So those costs are going to increase. We also see that individuals who are white tend to be placed in residential care, like licensed residential facilities, more so than other ethnicities. So this is important to take into consideration. The department and regional centers, in response to what we've been seeing in the data, there's a lot of activity happening. So about 4 years ago, the law was amended to require regional centers to post their purchase of service data and to meet with their local communities and to discuss with the local communities what the data was saying and how the regional center could take action to reduce disparities. Likewise, the department felt it was important to go out and to meet with stakeholders, and so last August we went to 4 different locations throughout the state and held stakeholder meetings to obtain information from consumers and families and advocates. We also placed a survey on our website to obtain more information from individuals. And when we did the stakeholder meetings, we heard some very common themes from families, that the regional center system is too complex, that it's very difficult to navigate, that it's difficult to understand, that they would like to have more materials in their own languages for them to understand the services that are available, that regional centers needed to be more culturally sensitive to their needs, that service providers needed to have the ability to speak their language and to be more accessible to them, and that the intake process was too long and too cumbersome. We also heard a very common theme about a lack of trust, that because regional centers are viewed as sort of quasi-governmental agencies, that there was a lack of trust between families and the regional center, so families weren't always willing to access services. So last year, the legislature passed legislation that provided our system with $11 million. And with that $11 million, the department put out guidelines to the regional centers, and the regional centers put forth proposals to address disparities. Our department approved 96 proposals amongst the 21 regional centers, and they are now in full swing of implementing those proposals. Some of the things that we've approved for regional centers is the translation of materials into different languages because the families wanted information that was more accessible to them. A lot of training for regional center staff and providers, promotora programs in several regional centers, and that sort of thing. Regional centers are also holding more orientations for families to come and to really understand what the regional center can do to assist them. And we've also approved funding for smaller caseloads. Regional centers have identified caseloads of individuals who receive case management, but they don't purchase any services for those individuals, and so they've made smaller caseloads to really come alongside the families to help them understand the system and access services. Our department is also really taken, like I said, a very keen interest in ensuring that this issue gets addressed. Regional centers were approved for funding for each of them to have a cultural specialist to really focus in this area. Our department is recruiting cultural specialists at this time to work with the regional centers. Our director has convened the Director's Disparity Advisory Group that is advising our department on how to address these issues. We do plan to go out on a second round of stakeholder meetings in the fall, so we might be in a community near you. We also, with our partners, we applied for a grant through Georgetown University, a Community of Practice grant, and we were awarded that grant along with 9 other states. So we're going to be participating in that to see how we can improve our system. The other way is just through continuing to analyze our data that we have available to us and understanding the root causes of the issues and what we need to do to address those. We have another $11 million this year to work with regional centers, and the law was amended to include community-based organizations. So we're working on guidelines that will go out to regional centers and the community to allow both regional centers and community-based organizations to submit proposals for funding to address issues of disparity. Lastly, we are in the process of getting a waiver amendment approved application from the federal government so that we can implement the self-determination program. It's a program whereby we can have up to 2,500 people in the first 3 years enrolled, and it allows consumers more control and more choice of the services and the people that provide those services. So we think that this is also going to help with some of the issues of disparity. And lastly, just creating a culture within our system of that this isn't a white program. This is really a program that needs to be very responsive to the consumers and the families that receive those services. So we have a lot of work to do, but we're well on our way, and we'll continue those efforts. So thank you.
All right. Can you guys hear me? Thank you, Brian. That was exciting to hear about the programs that you guys are implementing. Today, I'm going to be talking to you guys about some research that we have been conducting around strategies to engage underserved families in early intervention. So we know that engaging families in children's mental health service delivery is critical to family and child outcomes. So effectively engaging parents in their child's mental health service delivery has been shown to lead to improvements in child symptoms, child functioning, overall family functioning, and parent-child interactions. Many interventions that are seeking to improve the behavior of children with social, emotional, or behavioral disorders are actually intervening at the parent level on parent behavior as a mechanism for treating those child symptoms. And we're seeing this as increasingly true for children with autism, where parent-implemented treatment is becoming a primary intervention strategy. But when it comes to engaging parents of children with social, emotional, or behavioral disorders who are from traditionally underserved populations, and by this I mean racial or ethnic minority families or families with limited access to resources, we know that it's especially important to work to engage them in their child's intervention. And this is really because the attrition rates amongst low SES or racial or ethnic minority families are much higher than the rates that we see amongst higher SES or white families. And we suspect that this is due in large part to a lack of parental engagement. So at this point, it'd probably be helpful to define parent engagement, but that's easier said than done. So there really isn't a gold standard way that we measure parent engagement. Different studies have used many different ways, and it's been described in a bunch of different manners as well. So some places will use workshop attendance. Other places or other studies have used provider ratings of the parents' participation in the settings. They'll look at whether the parents completed their homework, or if and when a family drops out of a study. They also just look at if the parent made it to the end of the intervention. So clearly this captures very different levels of what we might consider to be parent engagement. And that's really one issue that we face when we're trying to understand the efforts in the community to engage families. Another issue that we face is that there really, just like there isn't a standard measurement, there really isn't a standardized strategy for engaging parents. So in order to increase parent participation, studies will choose locations that are accessible to parents. They'll let the families choose the locations themselves. They'll allow for flexible scheduling so that we can accommodate family and work schedules. They might also embed peer support strategies. So this can vary. It can look like facilitating relationships between the participants in the study. It could be embedding peer support groups into the intervention. Some studies also use peer or therapists who have been through similar experiences themselves, and that's called peer pairing. Similar kind of to what Brian was mentioning, some studies will use culturally informed practices, and so this might be modifying treatment settings or implementation or strategies in order to make families feel more comfortable. So for instance, you might see an intervention that's typically conducted in the lab one-on-one with a therapist and a parent, adapted so that it takes place in the home and accommodates the extended family, including grandparents or aunts and uncles. Studies will also use collaborative problem solving or shared goal setting in order to create a sense of shared power between the parent and the therapist. And then incentives are really commonly used. This can be gas gift cards, tangibles or gift cards for completing homework. It can also be food at the meetings, childcare, etc. So, due to the fact that there isn't uniformity in our measurement or our strategies for engaging underserved families, it makes it really difficult for us to understand which methods are most effective at engaging these families. We know that families from this population are less likely to engage in services and they're more likely to drop out, but we're not sure what the best way is to intervene. So we wanted to understand this problem, so we conducted a comprehensive review of the engagement literature. So we asked which strategies were most frequently being used in the community, just so we had an idea of what currently is being used. We also wanted to know which strategies were proving most effective, and that makes sense as well. So this review was conducted by the Autism Intervention Research Network on Behavioral Health, and this program called, well, I'll call it AIR-B because that's a mouthful. This is in its third iteration, and so under Dr. Stamer and Peter Mundy at the Mind Institute, we partner with the principal investigator of the study is Connie Kazari at UCLA. We also work with Pennsylvania, University of Rochester, and Drexel. And the goal of this network is to engage underserved families of children with autism spectrum disorder. So the literature search that we did on parent engagement yielded 330 articles initially. So we went through and reviewed the abstracts for these, and an article was included for the review if it targeted parent engagement and then also measured parent engagement as an outcome. If the children were primarily under 8 years old, so that they were in that early intervention system, the child needed to be identified as at risk of developing or being diagnosed with a social, emotional, or behavioral disorder. And then we wanted the sample to be primarily either under-resourced or from a minority background. And so following this, we eliminated 238 articles. So then we reviewed 92 articles, so 2 coders went in and read the full paper for those same criteria that I just mentioned, and following that, we excluded another 55. So in the end, that left 37 articles for us to review. So then we went in with the practice-wise engagement coding system, which was created by Lindsay and colleagues, and we coded this for the specific engagement strategies that the interventions were using and also how they were measuring parent engagement. So the most commonly reported measure of parent engagement was attrition, which we represented as the mean percentage of participants who dropped out of this study. We found that attrition was related to both parent and intervention characteristics as well as specific engagement strategies. And then this is the exciting finding. So peer pairing was the strongest predictor of attrition, which means that when parents were matched with a therapist who had a similar background to them, they were less likely to drop out of the study. So that means we think that engaging with the person who's delivering the intervention is at least as important, if not more important, than the parents' buy into the intervention techniques themselves. And so some of you might say that this isn't necessarily surprising because we know that parents of children with special health care needs have often highlighted the significance of hearing information from parents with similar experiences. Other studies have also indicated that shared experience can reduce feelings of isolation in this population, and that social support acts as a buffer against stress. But what's interesting is, despite the efficacy of peer pairing and our idea that this makes sense, it was the strategy that was least likely to be used in the studies that we reviewed. And then, to our knowledge, this is really the first review to highlight the significance of peer pairing in intervention retention amongst this population. So we think that this means that it's an important dimension of the engagement literature that's been understudied. Okay, so studies and citations are really important for helping us inform research and practice, but it's also important that we remember the clinical significance of these recommendations. So I want to share a video with you guys of a parent explaining the importance of peer support to her and her family, or in her journey with her child with autism.
If I had to think about initial advice I would think to get with a parent is to first know, because people, when you start off, everybody has their own idea. They have their thoughts, they have their own ideas on what they think works and does not work. You got to research it all, because you're being hit in all different directions, depending on the level of your child, you know, depending if they're verbal or nonverbal, or if they have other issues. So the first thing I would say is to obtain the information that someone gives you and research it, whether it be on the internet and whether it be a connection with a parent, because there's no other person that could help you navigate something than someone that has already gone through it. And believe me, they're out there. They're out there. They're either at a school that you might be at, or they're even at a services that you might initially start. But for me, what helped is that network as a parent, which we need to do more of, because you have parents that have gone before you that thought that didn't work, you know, or you need to try to go here, or here's a company, or here's a service, you know. That was the greatest, outside of my mother, the greatest thing that I ever did was getting a part into a group that would help to facilitate different services and realize that, you know, your child is capable of having them. They deserve to have them in order to move on in life, wherever that stage might be in their life.
So in order to help us get a better sense of these real-life experiences, we conducted focus groups as part of the AIRB project in Sacramento, Los Angeles, Rochester, and Philadelphia with underserved families who had a child who was diagnosed with autism. So we really wanted to hear about the experiences that these families had when they were engaging in the diagnostic process and also then trying to enroll in services. We spoke with 60 parents and 50 providers across the country, and we also conducted interviews. And we worked with our community collaboration to develop the questions that we were asking. The 60 parents and the 50 providers spoke to us in 37 focus groups or interviews. We then transcribed those conversations and then coded them qualitatively for information. 7 of the focus groups were conducted in Spanish or Korean so that we could get a sense of how language and culture really impacted families' experience. And then 30 of them were in English. So we developed 8 different codes to help us really pull out the important pieces of information from these transcripts. And I'm not going to go into all of the information about these right now, but I just want to share with you a couple of things. So this is an example of the ideas that we've been pulling from the parent focus groups. And so this parent mentions that she didn't have any support when she first got her diagnosis and was trying to get services, and that was really a big barrier for her in the process. She then mentions that now when she meets a family with a recent diagnosis, her first thought is to connect them to a parent group or to other parents so that they can have that peer support. So you can see that just like in our lit review, this idea of peer support being important to parents' journey is really coming up as well. This is an example of the kinds of recommendations we receive from providers. So again, kind of mimicking what you were talking about, Brian, the provider was mentioning different strategies that therapists could use to really build trust with the parents in this study, or sorry, the parents that they serve. So I just want to highlight the important pieces that we've pulled out of the recommendations so far. So parents and providers, and there is, again, a lot of overlap with what Brian was just talking about, but parents and providers both mentioned that when parents had someone like them who had been through the system before and could help walk them through it, that made a really big difference in their entry into the service system. And also they really just mentioned how much peer support groups, just connections with other parents really made a difference for them. And then other things that came up quite frequently across the groups were ideas for different ways that we could help inform our parents, including different ways that we could adapt the resources to make them more accessible for families. And then I want to point this out. The things that came up the least for recommendations from our focus groups were really those accessibility pieces that I mentioned as common parent engagement strategies from the lit review. So from this, we really see that embedding peer support into our interventions is important, and that is going to help engage these underserved families with autism and other social, emotional, and behavioral disorders.
Okay. Thank you, Sarah. And I'm going to stand to the side because I am a little vertically challenged, so hopefully you can see me a little bit better. So hello, my name is Elizabeth Morgan, and today I'll be talking to you a little bit more about addressing the challenges of early diagnosis and access to services for low-resource families who have a child or children with autism. But specifically, our objectives and what I really hope to discuss is common barriers and challenges that are within the African American community when it comes to having a child with ASD. And then we'll follow up with some of the research and strategies that we in research, but then also we in practice are doing at the Mind Institute. So I thought it would be fitting to start my presentation with a little story and give you really some perspective of my journey. So I am a proud mother of a 9-year-old now, Black African-American boy with autism, ADHD, and dyslexia. And you notice I gave you many descriptors, right, to describe him. And that's because it's all a part of his uniqueness. And it's really something that, if you look at this picture, you don't see any of those labels. You see a mother looking at her infant son, and you see what every mother looking at their infant son, for most part, sees: love and joy. And you know, what I didn't know at that point was that at 2 years, 4 months later, that we would receive an autism diagnosis, and how that really did change my journey, my experience, and my perspective. I always tell people that on November 9th, 2010, I walked into an assessment center, talked to a doctor one person, and I walked out a different person. And that's not to paint a glim picture or to be melodramatic. It really is just to reiterate that there is a transformation that happens when a diagnosis occurs in a family's life. And the truth is, I really wouldn't change a thing. I love my son through and through for all of those characteristics and uniqueness. So and I also realized that without that diagnosis, I wouldn't even be the person that I am today. So it's not a negative thing, but it definitely was a journey, because I have to tell you, starting out, I definitely didn't foresee my journey in parenthood, including having a child on the spectrum. But I have to also let you know, as I've had time now in the last 7-8 years to really think about, what it means to have a child with a disability, to be a parent of a disability. I also realized that there's some intersectionality that took place in helping to frame my experience and how culture was a part of that experience. So today, we're going to talk a little bit about how barriers associated with culture, specifically within the African American community, can really hinder parents from being able to become effective advocates for their child. And then also, we'll talk about some of the research that will help us understand how some of these interventions and ideas can actually transfer to other communities who are historically marginalized or underserved, and to be able to really support other communities of color or other communities who are having low resources. So I'm just going to give you a few stats that some of you might be very familiar with. So the CDC has reported that 1 in 68 children will be diagnosed with autism. However, we have research that confirms there's large disparities in access to care. And multiple studies have been conducted letting us know that early intervention really is key in supporting children being able to make gains in cognition and in language. So it really does make a big difference to have early intervention. But when we're looking at our Black students and our Black children in particular, many of them are being diagnosed outside of that window of early intervention. So although Black children are just as likely to have autism as white children, Black children are diagnosed up to from a year and a half to 5 years later than their white counterparts. And also that Black children are 1.2 times more likely to be initially misdiagnosed. So, we really have to look at what are some of the challenges on the child level, but then also the family level. And when we're looking at intersectional issues, when we look at families in poverty in particular, families who are falling below the poverty line are more likely to have a child with a developmental or disability. And that when you are poor and Black and have autism, you're even more likely to have these disparities in diagnosis. And once you receive diagnosis, are more likely to have less effective treatment outcomes. So through my work in the community, so themes such as what we've seen in the video have arisen throughout the time talking to Black families. And what I want to make sure to say is a little caveat is that the experience, of course, is not monolithic, and that there are many factors that can influence a Black family's experience. Socioeconomic class, of course, educational background, all of those things can absolutely impact their experience once they receive diagnosis. But I'm just going to highlight just a few in my short time with you of some barriers that we see. So the first one being lack of disability awareness. So the idea of uniqueness being accepted is something that is a theme within the African American community, but the topic of disability is still very much a taboo subject. So like in the video when you saw the couple that said, I just didn't want to take my child out, we couldn't take them to the family event. Well, because those things were being attributed to behavioral issues. And so families and the community really needing to have more understanding of disability is something that can definitely be a barrier. Another aspect is social capital. So social capital really are the social relationships that can help produce productive benefits. So having friends and family that have experience with disability or with autism and understand how to navigate the system really makes a huge difference in a family being able to help advocate for their child after that diagnosis. The last piece that I'll highlight is stigma. So the definition of stigma is it really referring to the attitudes and the beliefs that lead people to reject, avoid, or fear those they perceive as being different. So like one of the testimonials that one of the parents gave, that they were afraid of their child being ostracized or judged or ridiculed, and so they kept them home. So that's an isolation, but it's a double isolation when you're not only isolated from the outside community, you're also isolated from your inside community, your family base. So quickly, I'm going to tell you a little bit about what we've done at the USED, and to help respond to some of the research and some of the information, we have started up a group called African American Developmental Disability Parent Alliance. We meet monthly, and this is just a picture of, we're about 40 deep right now, and we're hoping to really expand and be able to do eventually satellite sites. But the whole goal is to allow caregivers who have Black children with disabilities the opportunity to share their stories, organize, and learn to advocate for their child. And we really cover a variety of topics, but the whole focus is to present information in a very culturally sensitive manner, using that peer-to-peer type of support, which is cultural brokering, to really help support families. So I'm going to leave you with a quote from one of our members. So as an AADDPA member, my confidence level for creating opportunity for my family is continually increasing. By taking the initiative to access services and supports for positive lifestyle changes, I have become a strong advocate for my child. And this is information about our upcoming meetings, which is also in our resource center. So
thank you, Elizabeth, and thank you for this great panel with their very thought-provoking information that leads up to my part of the presentation, and that is to share with you my many years of working with immigrant families. I'll be sharing some of my experiences. I have stories for you, and I have some recommendations of things that have worked and a story or two of what has not worked. So this picture was taken, that's me in the middle with all my little kids around me, and that was summer celebration when I retired several years ago. I forget how many now, but it's quite a few years back. And you see the kids with their little hats on, and they were celebrating their upcoming birthdays, their summer birthdays, which we always did. There's some siblings there and some parents. We included the whole family as much as we could. I retired, I mentioned that from SCOE, the Sacramento County Office of Education. I was a teacher there for many years, and retirement was welcome. 6 months later, one of my director from before called me, and she asked me if I would be interested in working at the SED as a parent advocate as an advocate for Spanish-speaking parents. So of course I said yes. So I retired from retirement. And I continue working with our Spanish-speaking families in the community, helping set up workshops and getting information out. And I also work twice a month at the Mexican Consulate's office, and I do developmental screenings for early warning signs, and I also talk to parents about developmental milestones. So I want to start with a quote from Supreme Court Justice Sotomayor. "We cannot solve all of the problems, but we can take a small piece to make a small change." And that really resonated with me when I was planning this. Made me think about all of you sitting here with your interest in serving underserved families, helping them, and remember that not one person can do it alone. We have to work collectively and continue doing what you're doing right now. Every small step, every resource, anything you take away from today's wonderful conference is going to be quantum leaps for our families that we serve. So who are the families that I've worked with for 30 years? When we first started, they were all immigrants from Mexico. And over the years, that's changed. Now we get families from Guatemala, Honduras, all of Central and South America. They have one thing in common. Most of them come here without extended family members. It's mom and dad, then they land here, and they have a child with a disability. So that makes them have one thing in common, the isolation. And I worked with this one lady, family who lived in the River Delta. And I was asking her, how else can we help you? You know, we've got physical therapy in here and all the services we had. And she said, I need to talk to another parent. And I think that was already mentioned by some of our panelists. She said, I'm just so alone, and I would love to have someone to speak to call in the middle of the night, call in the afternoon, and cry with, or laugh with, or just share my experiences. And I don't have that. Can you find that person for me? And it doesn't have to be a person with the same disability that my son has, but just any disability, any parent. So I talked to a couple other parents, and they shared the same stories with me. So what did we do? We started a support group, and that support group is going on 30 years now, and there's a couple offshoots from it, and we meet monthly, and some of those parents from way back then, whose kids are in their late 20s now, still come back sometimes, or always tell me, just have a parent call me. If you have a new parent, just have them call me. So that's been just a wonderful experiences with our families. Most of them come here with limited education. So we would talk about workshops and conferences, and they had no idea what we were talking about. I've helped many, many parents learn, not many, many, but some parents learn how to sign their name because of the limited education. Recently, we were going to an IEP meeting, and I told a parent, don't forget your notepad and your pen. And she said, what for? And I said, well, you need to take notes. And she said to me, I can hardly write. I've never been a secretary. I don't know what you're talking about. So I explained to her how important it was, and sure enough, she showed up with her notepad, and she took notes. And a couple of weeks later at our support group meeting, she was taking notes again, and she said, I really like this. This is great. So that's empowerment, right? What do we need? And then 17 years ago, we started a conference. It was Fiesta Educativa. It's no longer. It ran for 15 years. And we started with 75 families, and when we ended 2 years ago, we had 400 families coming. And the committee was mostly parents, and towards the last couple of years, many of our parents gave conferences, and we included the older siblings gave workshops, and the older siblings were included also. So again, that's empowerment for our families. And some of the other that's been mentioned already, the limited income, transportation, the rural areas, all of that. Monolingual, most of them come with one language, their own language. And they are dependent on interpretation and translation. We had a family from Guatemala, and we made our first 3 visits. Dad would answer all the questions. Mom wouldn't answer any questions, so that annoyed me a bit. And so I asked him, why? Why don't you let her speak? And he said, well, we come from an area where they don't speak Spanish, they speak Canjobal. And she speaks some Spanish, but she's not real comfortable. So my coworker went out and found somebody through her church who spoke Canjobal, and we were all excited, and it was a surprise for the family, and Mom and I were able to speak directly through this interpreter. And the next day, Dad called me, and he said, we don't want that interpreter in our house. We have a small Guatemalan community, and we don't want everybody to know our business. Whoops. So that was a mistake that we made in our enthusiasm and not asking first. But actually, it worked out well because the mom appreciated our efforts, and she started talking to me in Spanish. And so we were able to open that up for her, and we ended up having a really nice relationship. But it just goes back to remember to ask before you do anything. Always remember that. Let's see, they have a limited knowledge of our culture. They don't understand our values, etc. So we have to remember that many of them come here and they have doctors and teachers in very high esteem. They don't ask questions. I would go with them to interpret for their doctor's appointments, and we would talk about it before, and the parents knew what questions they were going to ask, and they didn't ask any questions. They come from small villages, and a lot of times it's just one story, and they get here, and we have all these big buildings, and that's a little overwhelming. Our food is very different. They would always ask me, how do you buy milk? I go to any supermarket, and you guys have like 30 different milk choices, and I never thought of that. So most of them shop at their own little mercados, their little stores, because they know the foods. So what we did through the infant program is we took a field trip. We'd take them to Rayleigh's, every semester, and we'd split up the groups, and we'd go around and show them the milk, the yogurt, the cheeses, our fruits, our vegetables, and we would give them recipes, and it was fun, and the families really appreciated it. We would take them to the downtown library, which you know is 7 floors. In the basement are all the books for the kids, little kids, so we'd sit down there and look through the books, and we'd help the families fill out an application so they could get their own library card. And then we'd go to I think it was the 3rd floor where they had all the books in Spanish, and at that time they had a lot of CDs that you can check out, and so that was really good. Recommendations. So these are some recommendations based on what I already talked about, and this was talked about earlier by Elizabeth and Sarah. Help them find other parents. That is so important. So they can share carpooling, their childcare, their resources, their tears, their triumphs. There's support groups almost everywhere in this area. There's quite a few. If you can't find a support group wherever you're from, just start one. We did. 30 years later, we're still going strong. So information in their community. There's always a leader, right? You meet this parent, that parent. There's always a leader who loves to get information out into their community. TV, radio, churches, everywhere they go, you can get the community out through this leader, 1 or 2 or 3 leaders. The Mexican consulate's offices, any gathering places. Your family resource centers and your regional centers are great supports, and they usually have all the resources. We're all working together, right? So we need to share information. We're all doing the same work. So how do we support their language? That's a tricky one because we often have interpreters and translators that are not culturally appropriate. And many families have complained to me about interpreters at IEP meetings, at doctor's offices, everywhere. So often the professional will be taking notes, or we check our phone while the interpreter is interpreting. And it's very important that you not do that. You keep an eye on the parent and see if they're feeling uncomfortable. You can usually tell when people are like just squirming around or not making eye contact. And you can check for understanding at the end. If you have something really important to tell them, like something medical, you can always ask the interpreter to ask the parent, can they tell me what I said? I just want to make sure I said the right thing. That's all very, very important. The parents don't have anyone to complain to. They can't tell the interpreter to tell you that they're not getting a good interpretation. And over time, when parents have been here a long time, they learn. They know a lot of English. They're just uncomfortable speaking it. Remember to not use acronyms and no jokes. Jokes don't translate. Often somebody would say something and then they would laugh and I'd have to translate and I have to go through all this thing. This is because our jokes are based on our history, right? And on our culture, and other people they're not going to understand that. Acculturation. You're here today because you want to learn how to work with other cultures. When our parents come over, they don't know anything about our culture, as I mentioned earlier. So tell them about it. Explain our medical system to them, our educational system. Encourage them to speak up, just like you and I do. We go to a doctor and they're going to give us some pill we never heard of, so we ask about it. And our parents need to do the same thing, so please talk to them about that. Don't use acronyms. Oh, I mentioned that. Respect their spiritual and their cultural beliefs. You know, they'll tell you they rub whatever to help their legs get stronger or something, and that's okay. As long as it's not going to harm the child, that's fine. Tell them that's okay. But do explain to them that we base everything on scientific research, right? Because that's how we are, and just tell them that. And to help engage with them, we have to earn their trust. This was mentioned earlier. So talk about what you have in common. You know, you walked in, they had roses outside. Well, I have roses at home also. So that's a conversation starter. And my last slide. So what do you know if you just see a turtle on a fence post? Well, turtles can't climb fence posts, right? So you know it didn't get there by itself. Someone helped. You can be that someone. You can be that person who empowers, who lifts up parents, to give them confidence to be their own self-advocate. Keep doing the work that you do and make a difference. Thank you.
Hi, good afternoon. Thank you, Angie, and everybody else who came along before me today and the past 30 years. Let's see, got a button here. This is Outreach That Works, and from a rural perspective, because it is hard to reach our families. We've got people out in the Yuba County foothills. Colusa County is ginormous, and people have transportation issues. Vendors don't want to serve these areas. There's a lot of windshield time involved. Early interventionists, maybe if they go out to these families and they're not there, becomes a real barrier. So while I'm not covering one of the underserved populations talked about earlier, rural definitely is underserved. So this is from a parent perspective. I'm Cindy Chandler. I'm the executive director for Family Soup. We're a family empowerment center and a family resource center, and we do some first 5 contracts. I'm a parent of an adult child. She turned 30 this summer, but the journey continues. She was on the autism spectrum, or I should say she is. Actually, Robin Hansen that you saw earlier today, she saw her when it was just UC Davis providing these kinds of diagnoses. But back then, when our journey started, it was when she was 18 months and the words went away, okay? She had the sensory issues. She had to have clothes from her neck to her wrists to her ankles. She had a limited diet. She ate 3 things. You could probably guess what they are. She had little eye contact, and she was definitely in her own world. If she was in her own world, she was happy, but don't try and make her transition to the next activity. And she was also still nonverbal after a year's speech at the age of 4. So it seemed back then no one had seen anyone quite like Emily. I'd ask professionals, have you ever seen anyone like Emily? And they go, no. Sunday school teachers, no. So there we were. It was a 1 in 10,000 incidence rate then. So but I didn't know that because I didn't have a diagnosis. So I'm alone, and I'm scared. When we finally got a diagnosis, then it was, okay, so now what do we do? You chase a diagnosis, then you get it, and then it's like, I'm in shock. And the videos that Elizabeth showed, we went through all of those. It was, that really was kind of devastating for me to watch those families. I could feel that pain. So what to do? So 3 other parents and I got together, and we decided to figure that out for ourselves and for all the families. And so 25 years later, Family Soup is still a lifeline for parents. Oh, and I always do this. I forget to tell you guys how it turned out, my nonverbal 4-year-old. So fast forwarding through amazing interventions and people in her life, really life-changing encounters that we had. She exited special education in the 5th grade. She graduated from Sonoma State University with an art degree. I wish it was something more, useful, but she is an artist. Yeah, that part of her brain is really, really good. She married her high school sweetheart. They live independently up in Spokane Valley, Washington, and she's a taxpayer, thank you. So miracles happen, but they don't happen by accident. Oops. So this is outreach that we're going to talk about that really works. So we can start with the Early Start 0 to 3 Family Resource Centers. So how does that work? Why do Family Resource Center work? They can make connections that allow parents to work through a grieving process. Because as you saw those families earlier, there's fear, there's denial, there's anger, there's guilt. I did this to my child somehow. I mean, it sounds unreasonable, but we all go there. We sit around in a support group and we all say, what did I do? So parents need to connect together so that they can go ahead and learn it's okay to dream new dreams and have hope again. So the Parent Resource Centers are staffed by parents that have children with disabilities. So that gives them that entree, of almost instant trust when parents sit across from you, and it's just that look, and they go, short conversation, they go, you get it, and they feel like they haven't had someone where it landed and they got it. It's sort of like when you're grieving the loss of a close relative, a friend, or a spouse, and you have to share that grief with someone where it connects, and that's that same connection that families can make almost instantly. So I connected with your parents in that video. They're staffed by families as volunteers or paid staff, and that's how it works best. We started as volunteers, and when we get shaky on funding and we're wondering what's going to happen next, we go, we would probably do this even if we didn't get paid. So, parent-to-parent support is key. It's because we can listen with our hearts, because we've been there, and I think that was mentioned several times earlier today. And then once we've made that connection, then we can help guide and support, and they can hear the information and they can hear the resources, and they go, oh, you did that? Did that work? What was that like? And I'm scared to go into a room with a bunch of people I don't know and sit in a big IEP table. And we are fortunate that we're able to go to those meetings with families, ISPs, IFSPs, and IEPs. Oh, so there's 47 family resource centers in California. So that is a statewide resource. So wherever you are in California, there's a family resource center. So that's ages 0 to 3. Then the family empowerment centers, they were legislated in the year 2000 with Senate Bill 511, and it was a unanimous vote to fund family empowerment centers throughout California. Now, it doesn't happen very often that you get a unanimous vote that involves money. So they provide information, navigation. Again, see that parent-to-parent support piece, runs throughout the disability system. So we can take families in that have a concern about their child, no diagnosis yet, we don't have any eligibility criteria, so we can take them all the way from a concern to assessments to those meetings and beyond. However, there were 32 regions that were designated for the state, but only 14 have been funded. So we're the newbies on the block, and we have a long ways to go to get the state covered. So if you live in an area that doesn't have an FEC, a Family Empowerment Center, go to your legislator and see if you can change that, because it's a law that's on the books. I think I already went over this. Sorry, I'm kind of jumping around here. But the important part here is that we really spend a lot of time empowering parents, knowing what their parent rights are. They come to us and go, I got this problem, my child gets kicked off the bus, and they have to get to their school. So we start with their concern, we listen, we do the intake, and then kind of give them the opportunities to go to workshops on parent rights and special education, but we will start right there and start calling, IEP teams and say, we have this parent, and we have this concern, and they like hearing from us. Nobody likes a surprise at an IEP meeting, so if we can kind of front load it, and then we're thinking we can even talk about, well, yeah, we could get an aide on the bus, or maybe we could shorten the route, maybe they could be the first one picked up. And so we do a lot of brainstorming. We are actually welcome at IEP meetings. At first it was like, oh my gosh, who are these people? But now it's more like, oh good, family soup's here, because sometimes it really helps to have someone to help pose the questions at an IEP meeting as a question, not as, so we ask, I tell the teams, I just ask the questions I would have asked if this was my child. And that seems to make it okay. And in the end, our parents do become their child's advocate, and we also work on the students becoming their own best advocate as well. To increase this kind of outreach, we need to have statewide coverage. And Elizabeth has a packet of where you can find your family empowerment center throughout the state. And then there's parent training and information centers. They are nationwide. We happen to have 7 in California. So that group serves ages birth to 26. So it's really cool because it takes you right through, all of the transitions and into adulthood. And so again, they have that information from a parent perspective, easy to use materials for parent rights and employment and entitlement programs and everything along the way. I like this picture, so you get to see it again. It just makes me smile. And I borrowed it from a presentation on promotores. How many of you are familiar with promotores? Okay, a lot of you are, some of you aren't. So what we're looking at here is they're members of their communities. They're the leaders in their communities. These are trusted people that know their specific community. They share language and culture, their ethnicity, and their experiences. And so these folks know the challenges and barriers specific to where they're living. And some regional centers use this model. And I'm not going to read you these slides, but you have it on your, flash drive. So if you want to know more about promotores. So they're important because they're going to build trust, or they already have the trust of their community. So the information they come back with is golden, really. So mental health uses this model. So in our area, our rural area, behavioral health did an extensive week-long training for promotores, and they learned about all the community resources. So that's why we connect with them. So they're familiar with what we do so that they can make those referrals back to us. And they're volunteers. So we recruited a couple of our parents to become promotores so that they could share their own personal experience with getting that kind of support if you have a child with a disability. Now, okay, so health clinics and Help Me Grow in our area. Help Me Grow is a national, you can become an affiliate anywhere in the nation. And it's kind of new to our rural area. Sutter County and Yuba County just signed up, so it's really not in motion yet. But the idea is the health clinics will now do ASQs, the ages and stages assessments. They weren't before. And then if they see red flags, they're supposed to let the health department know, because they're doing the Help Me Grow, and then Help Me Grow will make sure that they get the resources and services that they need. And the idea is that Help Me Grow does follow-up, follow-up, follow-up. They don't let anybody get lost. That's the theory. We'll see how it works. My big wish is that because in one of these meetings I asked, to the pediatricians that were all gathered around, do you do the MCHAT? To screen for autism? No. So that's next. I'll have them start, catching that early rather than waiting, it's a boy, he'll learn to talk eventually. So to recap, in my now 4 minutes, there's the Early Start Family Resource Center serving 0 to 3. That's funded through Part C of IDEA and goes through the Department of Developmental Services. Thank you, Brian. There's the Family Empowerment Centers. That's 3 to 22, Part B of IDEA, and it's through the Department of Education. There's the promotores, the health clinics connected with Help Me Grow. Then there's, I can't leave you educators out, childcare, preschools, and schools. You can be that person that our families connect with. When we put our child in your care, there's got to be a relationship that gets positive. And when you start working miracles, then you've got them. So for myself, that was my connection. The preschool teacher was a speech pathologist. She introduced ABA. She used a general ed preschool curriculum. She didn't hold back anything. It was just like, we're going to go with this. Whatever those other kids are doing, we're doing it too. She brought 5th graders in to work with the kids, and the kids loved playing with the older kids, and they would stage little plays, 3 Billy Goats Gruff. So have great memories of making that school connection. And then, of course, regional center with early intervention, early start services. You're in the home, you can make those connections as well. And I know a lot of parents grieve when those services end, and it's much harder, to put your child on a bus at the age of 3. This is our logo, and we just love what we do. Like I said, we'd probably do it even if we weren't funded. But my husband, when we first saw this logo, that's supposed to be the sun. That's our sunny guy, because we're optimistic. And he goes, "Oh, what a cute potato." And I go, "Gee, what does our pantry look like?" So we have all these amazing partners, husbands as well. He's been a great supporter, but when we started, it was, oh gosh, we'll add on to the house, because we're going to have Emily forever. And I was like, no, we're gonna change this. We're going to move on. So thank you for this opportunity to share with you at the Summer Institute the parents' perspective on reaching the hard to reach. We tell parents, don't do this alone. And our parents tell us, thank you for giving us hope.
So the question
What has
is,
been your experience working with families, especially immigrant families, who've been reluctant to reach out for services for their kids with disabilities because they're here and they're not documented?
well, when I was working in the infant program, we did get quite a few families who were not documented, but we didn't know it. Because we can't ask those questions. I did have a few families who, when we presented the program, they would say, it was usually with the mom, and she'd say, "Let me talk to my husband," and then she'd call me and say, "No, we don't want services." And I usually thought that that was why, although I never knew, but I always talked them into getting services anyway. So I imagine there are families out there, but I think once they get connected with an early intervention program, they understand that it's okay. I would tell them that it was okay, even if they weren't documented. Somehow I'd get that into that first conversation. But legally, we can't ask.
I had a question for Brian in regards to the disparities in expenditures between white and Hispanic. I assume the numbers you showed was for all ages. I wondered if you just looked at children, were the differences about the same?
So the differences between whites and Latinos, there still are differences even when you look at just for children or just for adults. Does that answer your question? Roughly, maybe a little bit less for children than adults because the expenditures are so much greater, but still definitely a disparity there. So the question is, what sorts of efforts are being made to really reach individuals who are in the underserved communities, especially the Latino community? And the $11 million that we had available last year and again this year, regional centers, as I said, we approved 96 different proposals. And so the Promotora model is one that about maybe 6 or 7 regional centers are using, but there are a whole array of different strategies that regional centers are using, even to the point of using sort of a robo-text system, because one of the things that Frank D. Lanneman Regional Center down in Los Angeles had noted is that oftentimes when a letter went to a family, because they didn't read English, it would just sit on the table and not be read. And when they were trying to invite families to come to community meetings, the families weren't aware of the meetings occurring. So they have invested in, through the 11 million, invested in a system whereby they can notify families in their own language about upcoming events. There's, like I said, a lot of materials being translated into different languages. They're just trying all different strategies to really reach out and make sure that families are aware of the services and that they can access them. So.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies upcoming events, and how you can help make a difference.